I'm Bobbi Fischer, and this is my Aesthetically Awkward Podcast, a show where we dive into all things aesthetics, health, wellness, entrepreneurship, and everything in between. This podcast is for informational and entertainment purposes only. It is not medical advice. Please consult your own healthcare provider before making any decisions in your personal health journey. Now let's get into it. Welcome back to another episode. Thanks for tuning in again. I'm really excited about today. I did a poll over on my Instagram stories and asked all of you what you wanted me to talk about next. There was a tie between hormones and lasers. So I decided I wanted to go ahead and bridge into some hormones. We are going to do a little bit of a deep dive into reproductive hormones, focusing first on females. I can go back and talk about males later, but the majority of my practice is female patients. I do treat men. 90% of my practice is female-based. Maybe you just want some more information and you've been on Google or WebMD and you're not quite sure where to turn. My focus today is to talk to you a little bit about estrogen, what it is, how it works, the symptoms it might be responsible for. I want to put fear-mongering to rest regarding estrogen. We are going to walk through the female lifespan, talking about puberty, moving through the reproductive years into perimenopause and menopause. We're going to be discussing menstrual cycles, how estrogen interacts with other hormones, what high versus low estrogen might look like for you, and what treatment options are available. It's meant to be educational. This is a patient-facing episode. This is not meant to be education for other providers. It's not to tell you what you should do. It's to help give you a little bit more clarity so you can bridge this conversation with your provider and make an informed decision to pursue treatment should you choose. Before we get into that, it's time for the Behind the Mic segment where I share a flex or a flop that I've had over the last week. Those of you that were here last week know that I was sick. My entire family was sick. We got back into the swing of things. My kiddo went back to school. I'm back to work. She had a holiday party yesterday and I missed the memo that parents were invited. I had no idea. I picked her up from school and she said, "Mommy, why weren't you there today?" I'm like, "What are you talking about? All the other mommies were there." "What do you mean?" I had no idea that moms were supposed to be there. I just thought that it was a PJ day. I was under the impression they were watching movies all day and that the parents were bringing snacks. I had no clue. I felt horrible, absolutely mortified. So I've gone through my calendar and any other upcoming holiday party throughout the rest of the year that is noted on the school calendar. I just took the day off and I am anticipating that I'm going to be there. I'm going to be with my kiddo at school, so this does not happen again. Well, let's get into estrogen. It's not one specific hormone. There are several forms of estrogen, each with different roles, different levels of potency in the body, and that is all age dependent and reproductive status dependent. The most biologically active estrogen is estradiol. It's the most dominant estrogen during the reproductive years. It's responsible for regulation of the menstrual cycle, supporting ovulation, maintaining bone mineral density, influencing mood, brain function. It supports your cardiovascular health, and it plays a significant role in your metabolism. Estrone, it's a weaker estrogen. It becomes more prominent after menopause. As your ovaries start to produce less estrogen, estrone comes in. It becomes the primary circulating estrogen. It's largely produced through the conversion of adrenal androgens in adipose or fat tissue via an enzyme called aromatase. And then you have estriol. It really becomes significant during pregnancy. When your placenta produces large amounts outside of pregnancy, estriol really exists in very small amounts. It acts as a weak estrogen and it's really localized. Before menopause, the ovaries are the primary producers of estrogen, specifically estradiol. As women age and their ovarian function declines, estrogen production is going to shift away from the ovaries towards your peripheral tissues. And what that means is after menopause, your estrogen is produced elsewhere in the body. It's produced through aromatization in your fat tissue, in muscle, bone, skin, and even in the brain. When estrogen starts to disappear after menopause, its effects feel different for so many people because it is found and it's created in so many different tissues within the body. How estrogen works, it binds to estrogen receptors throughout the entire body. These receptors are found not only in reproductive tissues, but also in bone, brain, blood vessels, and your skin, the GI tract or the intestinal tract, the GU tract or your urinary system. So when things are imbalanced, it kind of makes sense why a woman can feel like her body is going haywire out of nowhere. During puberty, estrogen levels start to rise in developing females. This drives breast tissue, bone growth, maturation of your reproductive system, and shifting into the reproductive years, estrogen follows a cyclical pattern. In the follicular phase of your menstrual cycle, estrogen gradually rises as your follicles start to develop within the ovary. That thickens your uterine lining. It sends feedback signals to the brain that trigger ovulation. Estrogen peaks around ovulation, and that peak influences everything from cervical mucus, libido, energy, motivation, and cognition and mentation. After you ovulate during the luteal phase of your cycle, estrogen remains present, but it's balanced by progesterone. This helps to stabilize and prepare your body. But if pregnancy doesn't occur, estrogen and progesterone both start to decline, and that is what triggers menstruation. The fluctuations are normal, but if estrogen is too low, too high, out of sync with your progesterone, that's where symptoms start to arise. Perimenopause is a term that some of you might be familiar with, and it's not defined specifically by low estrogen, but more by unpredictable or volatile estrogen. Levels can spike higher than expected and fall abruptly. That hormonal shift is what drives perimenopausal symptoms like irregular heavy cycles, breast tenderness, worsening PMS, sleep disturbances, anxiety, mood changes, migraines. Menopause specifically occurs when the ovarian estrogen production has significantly declined and menstruation stops altogether. Let's talk about estrogen's reach outside of the reproductive system. So in your bones, estrogen helps maintain the balance between bone formation and bone breakdown. When estrogen starts to decline, that is when bone resorption accelerates. And that's why declining estrogen leads to the risk of osteoporosis and an increased risk for fractures. In the brain, estrogen interacts with neurotransmitters like serotonin and dopamine. That's really where estrogen is tied to changes in your mood, into anxiety, your focus, and to sleep disturbances during hormonal shifts. Your cardiovascular system. Estrogen supports the vascular flexibility and how your body metabolizes lipids. Estrogen is directly tied to insulin sensitivity and fat distribution. When a female's estrogen starts to decline, many women will notice increased central or abdominal weight. Those changes in your body composition are directly correlated with a shift in your metabolic efficiency. Low estrogen can also present as hot flashes, night sweats. You may have concerns with vaginal dryness, painful intercourse, low libido, sleep disturbances, joint pain, mood changes. High estrogen, or sometimes you'll hear it referred to as estrogen dominance, that usually occurs when progesterone is insufficient or low. You might see heavy or irregular bleeding, breast tenderness, headaches, worsening PMS. So once you start to understand what estrogen does, how it changes across the lifespan, the next question is often, what can I do to prevent it from affecting my quality of life? Management doesn't necessarily start with medication or replacement. Not everybody needs or wants hormone replacement therapy. There's some non-medicinal approaches, especially when symptoms are mild or early. Sleep quality, stress management, movement, nutrition, all of those factors are going to influence how estrogen functions within your body. Chronic stress alters estrogen's interaction with cortisol and progesterone. Poor sleep impacts your estrogen's relationship with insulin and appetite regulation. Your body composition matters because adipose or fat tissue plays a direct role in estrogen conversion, especially after menopause. Whether or not you're going to be using hormone replacement therapy, making sure that you are directly addressing these root causes is going to be supportive of how you are able to navigate perimenopause and menopause. There are some non-prescription options that some people like to explore, like supplements or plant-based compounds. They may offer mild symptom relief for some individuals. They're not the equivalent of taking estrogen replacement therapy, and they're not regulated in the same way as prescription therapy. Natural doesn't automatically mean that it's safe or effective. Definitely see a practitioner that can help guide you, do a full assessment, and determine if it's going to be a good fit for your needs. If your symptoms are moderate to severe, when your quality of life's being impacted, it may be time to consider estrogen replacement therapy. It's an important option to discuss with your provider. There are many FDA-approved indications for vasomotor symptoms and genitourinary symptoms of menopause. The goal of therapy isn't to recreate a youthful hormone profile. It's to relieve symptoms, protect tissue, improve your overall well-being and your quality of life. There's a few different options. You've got synthetic or bioidentical. Bioidentical means that the hormone that you are taking is structurally identical to what your body is already producing. Doesn't mean that it's 100% risk-free. Synthetic is not identical to what your body creates. It doesn't automatically mean that it's harmful necessarily. What matters most is formulation, dose, route of administration, and your personal health history and your family history. Estrogen can be delivered orally, transdermally, locally. It can be delivered via pellet. Oral estrogen passes through the liver first. It's called the first pass effect of the liver. That can influence clotting factors and lipid metabolism. Transdermal estrogen, patches or creams that are applied to the skin, that's absorbed through your skin and enters the bloodstream more directly, and it helps to avoid the first pass liver effect. We've also got local therapies like local vaginal estrogen. There are tablets, there are creams, suppositories. That works primarily at the tissue level. There's minimal systemic absorption. That's why it's often considered, even in patients with more complex medical histories, if you have concerns with breast cancers, sometimes the benefits outweigh the risks there, and your provider may prescribe you local estrogen for vaginal symptoms. I'm very intentional with how I choose to prescribe estrogen. I don't like estradiol pellets. That's my personal preference based on the way it's dosed, how you can adjust it, and patient safety. Once a pellet's inserted, you're locked in for at least 3 months. So if you have adverse symptoms or reactions, there's not a lot that we can do aside from support those symptoms. So I choose not to replace estrogen via pellet therapy. There are some providers who do that, and I respect that. It's just not what I like to do. I prefer patches and I prefer creams because I have the ability to adjust that dose for my patient. I do like to do bioidentical compounded creams for some patients. I'm very selective with the compounding pharmacies that I use. I have been with the same compounding pharmacy for my reproductive hormones for several years now because of the quality and the consistency. And I love transdermal patches. The transdermal patches are typically covered by insurance for most of my menopausal patients. They can be life-changing. The dose can be adjusted easily. We start low, we titrate up as needed, and the copays are usually fairly insignificant. Estrogen therapy should always be individualized. There's no one size fits all for hormone replacement therapy. Your age, how many years it's been since menopause, when your symptoms started, how severe the symptoms are, cardiovascular risk assessment. Do you have high blood pressure? Do you have high cholesterol? What's your family history? What's your breast health history? Your personal preferences. Are you going to be able to consistently apply a topical cream every day? Or do you know that you have a hard time taking daily medications anyway? So is a patch going to be better for you? Those things matter. It's not about pressure. It's just about making an informed decision that's right for you. And there needs to be flexibility with whomever is managing your hormones. Let's also talk about cancer risk. There are some high quality studies that show low dose vaginal estrogen does not increase your breast cancer specific mortality, and that estrogen only therapy in appropriate populations has not been associated with increased breast cancer incidence, and it might even reduce your risk for breast cancer in certain populations. This really just reinforces evidence-based conversations rather than blanket fear-mongering. At the end of the day, estrogen management, it's about quality of life. If you choose to support it through lifestyle changes alone, that's valid. If you want to go the medical route, by all means do that. If you prefer to do supplement, I respect that. The most important thing for you is that you are making an educated, informed decision, that the treatment plan is personalized to your needs, and that you're supported throughout that process. All right, now we are going to get into the part of the episode where I answer real questions submitted by listeners. So I had some polls and questions up in my Instagram stories, and moving forward, that's where I want you to send any of your episode specific questions. I'm going to have polls up for you to vote on, and that's going to help guide our conversations and episode topics. Remember that my Instagram is at Bobbi the NP_Luxlift, or you can also follow the podcast page directly at Aesthetically Awkward Podcast. One of my viewers on Instagram had asked me, I have an adhesive sensitivity and I've tried patches in the past and had to stop them. What can I do? So this person was talking specifically about estradiol patches. Risk for sensitivity is low. It's never zero. So if you've tried a patch before and it caused any rashes or sensitivities, I 100% support stopping that therapy. For somebody who wants to do a transdermal route but cannot tolerate a patch, that's where we start talking about creams. I know that I'm getting ready to go into menopause. I have a period every 3 to 4 months. When can I start hormone replacement therapy? Now. You could absolutely start now. Talk to your provider about it. If you are having hot flashes, mood swings, breast tenderness, low libido, if you're having any vaginal discomfort or painful intercourse, now is the time. You don't have to wait until your periods stop. I encourage you to have that conversation with your provider now to improve your quality of life. You do not deserve to suffer through this shift. As we prepare to wrap up, I hope that that you're walking away with a little more clarity and less fear regarding estrogen. I hope you have a better understanding about what it is and how it works within your body and the symptoms that you may or may not be experiencing, or at least you're better prepared for when those symptoms may arise. No matter where you are hormonally in your lifespan, your symptoms and your experience are valid and you deserve care that supports you through that. If you're left with questions, that's a good thing. Follow me on social media, slide into my DMs on Instagram, watch my stories, participate in the polls. In the meantime, bring those questions to your provider. If they can't answer them, or they're not prepared to help support you hormonally, you may need to consider consulting with another provider. You're allowed to advocate for yourself. If this episode was helpful in any way, share it with someone who needs it, and be sure to leave a review on whichever platform you're listening. I appreciate you being here, and I will talk to you next week about progesterone.